Have a seat, quick.
Can we use his computer for the presentation? Because it's already on the PowerPoint from his computer.
Okay,
Yeah, probably.
Well,
but you
someone
don't
else is getting
Okay.
their computer. I shared it to.
Jason.
Oh, okay, so Jason is gonna bring it. Okay, perfect. We do it.
Thanks.
Okay, ladies and gentlemen, good morning and thank you. Welcome to the SBHIBC. We have two and a half speakers.
Who's the half?
Basically, we have Dr. Carla Torres, who I'm going to introduce to you right now. She has earned a degree, for a little background, she earned a degree from the Universidad de Baja California in Mexico City, the Autonomous University in Baja California. Oh, no, I said Mexico City, in Baja California, excuse me, in Mexicali.
That's where you were born.
Yeah, there you go. Mexican, and holds a master's degree in the science of nursing, with specialization in family nurse, as a family nurse practitioner. She is also certified as an HIV specialist, and by the American Academy of HIV Medicine. And she is studying to be for statehood because she is such a nice person. And I think she's already earned a master's there. Since 2002, Dr. Torres has volunteered at the agency of.
We miss you. Thanks. I'm fine. I'm good. You're on Zoom. You're on Zoom.
Exactly, it's very much similar to Family Health Center. So it's a nonprofit in Baja California, in Tijuana, where she serves as the medical director and provides care and social support for marginalized individuals living with or affected by HIV and AIDS. AFABI is the partnership with AHF, founded the first HIV clinic in Tijuana in 2005, which is just absolutely wonderful. If you think about the fact that Mexico, in general, you could say is about 10 years behind what happens in the US. And it's people like Dr. Carla Torres who bring it up, try to bring it up to the time, to current times. But the availability of medicines, et cetera, is very limited down there. Since 2000, currently she works for VIV, which is VIIP Healthcare, which is a pharmaceutical company solely dedicated to the prevention and treatment of HIV. As an HIV community, community medical liaison in the division of North America Medical Affairs. Dr. Torres is responsible for educating communities about HIV. We would like to thank her very much for speaking monthly about HIV and how it affects different organs in the body. Today, we will discuss the liver. The liver is and its special relationship with HIV. Without further ado, Dr. Torres.
Okay. Sure.
Yeah, there's a script by part.
A wonderful honor and pleasure to have this opportunity for our conversations. We know my goal is to create a safe space where we can have a discussion around topics. I do not claim to be a specialist in everything, and so we're here to just have a little dialogue. I'll try to guide our conversations. We've been going through different organ systems through our conversations in the past. Today, we're going to focus on the liver. And it's actually part of our 18 series that we address. And when we get let's start off with what is the liver? The liver is an organ, a vital organ in our bodies. It's located in our abdominal cavity. It's located right below the right side of our rib cage. So understanding that that's where the liver sits and its responsibilities are many in keeping the balance in our body or keeping our body healthy. So what do you think the liver is involved in? What are some thoughts? What does the liver do?
Filtering alcohol, filter.
It's a filtering alcohol. Anything else?
Actually, it's not filtering out, it's preferred to filter. Yes.
It's difficult, yeah.
He was being facetious.
Big monster.
Anything else that, I think everybody's kind of familiar with that part of the liver, that like it's part of our filtering system, and we have other filters in our body, but the liver is part of that filtering process, especially for alcohol. Any other functions that the liver is in?
Metabolizing whatever you eat.
Yeah, metabolism, digestion actually has a really important role in digestion. Why? Any
What's the
thoughts?
difference between the liver and the kidneys?
Oh, different type of filtering. So we, in regards to like the kidney filters more, the blood and its output is the urine for the kidneys, right? It actually has a way out. The liver has a little bit more of a difficult time with that filtering because once the liver is not filtering.
They both do the filtering? for the
Yes, some filtering from the blood. And the big thing with the liver, when the liver is not working, it's really tough. It's such a vital organ that at least the kidney has a way out, right? But the liver, and we'll get into the functions of the liver, but it is difficult. So we talked about the liver being involved in detoxification or detox or filtering, digestion, because what's really important that sits in the liver that's also participates in digestion, our gallbladder. I was thinking in Spanish, but our gallbladder also sits right in the liver, is nestled against the liver. So it has a function of the metabolism.
In Spanish.
Vesicula biliar, and that's all I could think about in Spanish, vesicula biliar. So the gallbladder also sits right there in the liver. It's nestled in the liver. But when we talk about the liver, what would be in HIV? What are some thoughts about HIV in the liver?
The drugs kill it.
Medication. Right, because living with HIV requires lifelong treatment. And because there's lifelong treatment, there's a metabolism part that includes medications, right? And so when someone's living with HIV, monitoring their liver function is something that we routinely do, right? We get blood work. Our blood work has been much more separated than it was in the past. We used to start checking liver function tests like every 3 months, every 3 to 4 months. People now sometimes have general checks and monitoring of their HIV. And I'm gonna go to this next slide. So when we talk about the liver and as we've seen with medication that's used to treat HIV has evolved and has become much more better tolerated, what we see is people living with HIV living longer, having longer, healthier lives. With that longer life, we've talked about aging in itself, right? And our aging process is going to be an individual process for each one of us. We know that there are some common denominators, but in our aging process, we each have our own fingerprint, right? In that fingerprint, we've talked about all the factors that can impact the aging process that are individual, from genetics, lifestyle, co-occurring conditions, all these things that can impact our aging process. But getting to be older means we need to, or we're here to start having to deal with issues that in the past were not very relevant, right? We didn't worry too much about what was going to happen with the liver because we were in a different mentality, right? We were reacting, right? And now, as medications are much better tolerated, we're going through the process and talking about how we just had these conversations about each organ system. And we're going to continue talking about each organ system. Today, the focus is liver. We are talking about these because people are living longer with HIV. And our health in general is impacted as we age for all of us. But what that factors in with HIV is something that we are also adding to the conversation. One of the common conditions that we see in people living with HIV is has changed its name, or I know that it is more commonly known as non-alcoholic fatty liver disease, or all of you have heard of fatty liver, which is a more common terminology. The medical terminology that is we refer to evolved and now currently how medically we refer to this condition is the metabolic dysfunction associated to steatotic liver disease, MASLD, okay? And then the other classification is metabolic dysfunction associated to steatohepatitis, MASH, which used to be called NASH. So those two liver conditions, the one below the MASH is a little bit more serious because we're actually talking about liver damage. And then the fatty liver, and you could see in this slide up here, a healthy liver and a fatty liver. The deposits of fat impact how that liver functions. Yes.
So they're not making a distinction over alcoholism anymore?
So alcoholism, and let's talk about what can impact the liver. Alcohol is one of those things, and can definitely hurt the functioning of the liver. We're going to talk about this condition that's more common in people living with HIV, which is non-associated to alcohol, but definitely alcohol can lead to liver dysfunction for the liver not working properly. So
Dr. Gordon, would you say that, like I take 16 pills a day, okay? If that is also something that could cause this, in other words, that the liver can't filter that quantity and.
So polypharmacy or having many medications, the one we're taking is something that we monitor for the liver's health to be able to take on. Different medications have different metabolic pathways. Not every medication is metabolized through the liver. Some medications are metabolized through the kidneys. And so there's different pathways. The more medications we get, the more complicated it can be. So not necessarily that it's going to cause liver damage when we're taking a lot of medications, but potentially the risk of interaction is something that the provider, your doctor, is monitoring. So
We're also, people with HIV, and I look at this as a positive, okay?
Yeah.
Are pretty much hypochondriacs anyway, you know, because every little pain, we rush to the doctor, but then again, if it is a problem, we catch it early, right? But what about that? I mean, it's on the right side. What are the symptoms that we should be looking for?
I love that, John. Thank you for it.
And you also said the liver works with the gallbladder. And since I don't have a gallbladder anymore, they said they told me that's actually where the fat was processed. So without that, does that mean that my liver now has to take all of the
Job of the filter.
So even without the gallbladder is a separate organ that lies within the liver. But the liver also participates in the metabolism of fat. And even we have a lot of people that are missing their gallbladder and are still able to process because the liver also has function in helping us metabolize fat. I want to make sure, because liver is such a big topic, today we're gonna focus on this part of the liver, on this type of condition that impacts the liver, because it is something that is most commonly seen in people living with HIV. Like we said, there is liver disease caused by alcohol. There can be liver damage associated to medications. And that is something that your doctor looks at and considers when adding certain medications because of how some medications are metabolized. But I want to make sure that we address this because again, this is one of the most common scenarios. Looking at how and why would this happen in people living with HIV? What we talked about living longer. As people live longer each year that we're here on Earth, most of us tend to gain weight. They talk about a 1 to 2 pound weight gain that comes as we get older, right? So weight gain naturally as we get older occurs. With other things that we know affect weight in people living with HIV, we know that medications can impact weight, genetic can impact lifestyle, all these things in general can impact weight. But weight, having an increased weight puts us at risk for having issues with our liver. So I guess I wouldn't normally worry too much. And like, as we heard from the group, we're thinking alcohol in the liver. We're not thinking fat in the liver, right? It's not something that was something or that we're as concerned about, but it is something that we see in people living with HIV. So we talked about these two conditions. Like we said, MASH, which used to be called NASH, is associated to liver damage. But I was going to go back to John's question. What are some symptoms of when the liver's not working?
Pain in the right side.
Some pain?
Jaundice.
Jaundice. And so what is jaundice? Some people don't know what that word is. Turn yellow, right? And so
Is that bilirubin that makes you yellow?
yes, exactly. And so, and here I got reminded, like even in the past, and many of you know, there were medications that like atazanavir, which is a protease inhibitor that used to cause yellowing of the eye. Some medications impact the color of the urine, but when the liver is impacted, and I always give this good visual for people who drink Coca-Cola. I like Coca-Cola. We call it urine turns dark like Coca-Cola. So you'll always remember that. That's a sign that the liver is not functioning properly. The yellowing of the eyes, the yellowing of the skin, the stools become light. Or have no color. So instead of having the normal coloring, you see light color stools. Is talking about the liver. We can, as if the liver gets more and more impacted, there's more and more symptoms. The liver is also involved in making sure that our blood clots and so there can be signs of or more risk of bleeding. Water can accumulate in our abdomen as well. So people can get a bigger stomach. There's loss of muscle mass. So there are that's severe issues with the liver, okay? Most common signs can be fatigue, tiredness, that coloring in the eyes might be earlier symptoms of something that's impacting the liver. Let me go to the next one. So when we talk about the two conditions that impact that fatty liver condition, it's even in people that don't drink any alcohol can be impacted. Their liver can be impacted in this way. And so it is potentially, some people can have no symptoms initially. The fatty deposits can start little by little. We know that one of the things that we monitor is liver function tests, right? So we actually have a panel blood test that looks at the liver enzymes that your provider is looking at and keeping track of. So if the liver is impacted, we could start to see subtle changes in the liver, right? And so here are those very vague symptoms that can appear when the liver is impacted. So like fatigue, we know if someone comes in with a complaint of fatigue, it's a very generalized symptom, and we have to actually look at everything that could cause fatigue. And one of the things that could cause fatigue is having issues with your liver. Your appetite might be impacted. The jaundice that we talked about, the yellowing of the skin and eyes. There can be the discomfort in that right side that we were talking about, and there can be some weight loss. So it's important that subtle symptoms, but one of the things that, and if someone's living with HIV, we're consistently checking labs. So your provider will most likely would start to notice if some changes in those liver enzymes are happening, and I could potentially correlate that to some symptoms that present, or someone that starts to complain of some of those symptoms.
We used to call it lipoatrophy and lipodystrophy. You're blaming Xerid at first when your legs got real skinny. And then you got the fatty around the liver, which is also with alcoholism, but.
Yeah, but it's so that's a really good point.
In the
So
back of your neck, how the
the hump, right? The buffalo hump that we used to talk about, the lipodystrophy, which with atrophy and then hypertrophy. So atrophy would be the loss of fat in the face, arms, legs, buttocks, and then accumulation of fat in the abdomen was associated to some of the toxicities of the medications in the past, right?
They're blaming the meds.
So in the past,
HIV.
it was associated to the meds, to the toxicities of the medications. And so medications as they evolved did not impact the metabolism as that. And so we rarely now see those fat losses or fat accumulations. But we have a lot of people that have lived with HIV for a long time. And we, as we've talked to this group, depending on what decade you were diagnosed, you were exposed to different medications, right? And we have people that have now lived with HIV for many decades. It's not going to be the same story if you're diagnosed in even in 2010, right? It's because the medications that are available are very different, and we've evolved. So kind of what we do see in someone who has their liver impacted, we in this case, is we can see some fat loss in the arms, some loss of muscle, but the accumulation that we see when someone's liver is impacted is mostly not that fat that we used to see in the past. So that abdomen that
Was it like a damage done? I mean, once it's there, how the hell do you get rid of it?
Right, and from the past, I still see people that are left with that accumulation of fat from the old medications, right? In this condition that we're talking about, fatty liver disease, you wouldn't get to see that fat. So the fat of someone who has, I'm really running short on time. The fat accumulation from that that we were talking about, that belly
So there's
fat.
a difference though.
Yeah,
Oh,
yeah.
okay.
So the belly fat in there is hard.
Mm.
It's not a soft belly because the fat is on the outside, and so it's a little bit of different. But that was related to medications and toxicities of the past. Okay, so this would be a little bit different.
Those symptoms that you had up there before, are they progressive? In other words, if you don't have it, then you're in a relatively good liver stage. But if you do have those symptoms, then it's progressively getting worse.
Exactly, and
Okay.
they actually stage your liver disease depending on what symptoms are presenting. So exactly, so someone can have no symptoms, but it means usually their liver is not that impacted. As it's more impacted, we can see more impact on the liver. And so we have 5 more minutes, so I'm gonna try and and like what I see is there's more interest of us talking a little bit more about the liver. So this is something that we can continue on and have a greater conversation. Maybe just talk about alcohol in the liver and how that's impacted, or talk about medications and drug metabolism might be something important. So fatty liver, because this name is so complicated, let's just call it fatty liver. It impacts people living with HIV as we get older. And the risk factors is having high cholesterol levels. We know that the current recommendations for people living with HIV recommend that we monitor cholesterol levels really closely and talk about statins as the recommendations if you're 40 years of age and older. For most people, the recommendation if you're living with HIV is to have the discussion with your provider about starting a statin. And here we could see why controlling controlling our cholesterol is so important, because there's consequences to having our cholesterol not being well managed. diabetes as well can impact this. We know that we talk about screening for diabetes, so the risk associated with diabetes. The risk is as we get older, we are at higher risk. If we're overweight, we're a higher risk. So being overweight in itself puts us at risk for many conditions, from fatty liver to diabetes to high blood pressure to cardiovascular disease, a lot of things associated to weight. Again, we know that HIV and the treatment for HIV, there's a lot of conversation about medications that are newer medications that have a role in weight gain as well, right? And that is something that as we age, the medications that we're on, our genetics, our lifestyle, everything can impact weight, and weight in itself is a risk factor for all of these things. Again, the messaging about this is staying healthy and exercising, as all of us need to do, because of the consequences that could come with that. And so just older, overweight, diabetes, and especially diabetes with uncontrolled blood sugars and high lipid and cholesterol. I always encourage you to talk about when was the last time I was screened for diabetes. I would tend to do it once a year, especially if you're 40 years of age and older. Your cholesterol once a year is a good, and then be fasting for your cholesterol checks. Talk about your weight with your provider. It's a really important conversation. Where am I in my weight? A BMI is a general indicator, but it's not the tell-all. Losing 5 to 10 pounds is a significant help for us. And just starting physical activity, start by counting steps, which is not a huge deal. Look at your baseline. And then from there, you can start slowly increasing the number of steps. And so, and these are the recommended.
What role do triglycerides play?
As well, so triglycerides is considered a fat as well. We know that triglyceride levels impact our general risk. We've gone through times, because I'm that old, that triglycerides weren't that important, and then we're like, wow, they're really important.
Yeah.
And started talking about, again, in HIV, initial medications that were available would spike triglyceride levels.
Very high.
And so the metabolism for triglycerides is impacted and has some correlation with carbohydrates and our diet. So there is also a risk having higher triglycerides and a concern for diabetes might be along the way. So it's still an important, it's part of that lipid panel, and it's still part of the conversation that needs to be addressed in regards to every other risk, right? That we need to take. So talking about diet, vegetables, and a better balanced diet, trying to avoid fat, sugar, not as much salt as well. And then alcohol in itself is also a conversation that's important, right? We know alcohol is metabolized in our liver and impacts the health of our liver. If we're taking so many medications, again, there's medications that interact directly with alcohol. So it would be a concern. Increasing our physical activity, as we talked about as a group, walking, encouraging us, like I've always been for dance parties. Anything that we could do that could get our physical activity going is something that'll help all of us. So considering that as we age, we need to keep into consideration. And when we talk about living with HIV, it's not very different of the conversation I would have with anyone who's going through the aging process. We have some cofactors that we have to consider, but in general, this is the same thing for all of us. As we age, we need to incorporate these messaging. And a question or 2 minutes. And any other questions? No, that's great.
Yeah.
You're good.
What about to receive of a pig? Animal? Liver?
Oh, liver transplant from a pig. I think I've read about it in the news. I think they're working on it. It's still kind of out there, not something that's gonna happen widely. So I think our messaging would be take care of our liver that we have right now here, and then don't hold out hope for that. I think that's not something. But remember that like the empowerment tool is what we do today can impact what's coming up for us, right? And we can slowly start taking steps that to help us in that manner. And taking care of our liver is one of those organs that is really important and that we have to be on the lookout in a different way than we normally. So it's not only alcohol, but just my messaging, understanding that our weight, our cholesterol, our blood sugar also impacts the liver. And this is something that maybe we didn't give as much thought, right? We thought liver, alcohol. If I'm not drinking, I'm okay. But what if I'm overweight and have all these other conditions? That's something that we need to pay a special attention. So just a little bit of a different perspective. And I think I'm at time. And thank you, everyone. I'll stay here for if I can answer any other questions. Thank you so much.
Thank you. The message is stay healthy. You put what you put it, you know, what do they say in accounting, first in, first out. You have to really put healthy things in you, make part of your
Jason.
goals be drink water, stay on a healthy diet,
But
and exercise. You know, make sure you exercise, make sure you stay healthy. Mediterranean diet is probably the best diet you can be on,
You got it?
or something related to that. Don't drink alcohol.
Yeah, I never saw a fat drink.
Yeah, I quit drinking a long time ago. We are pleased to have Dr. Taylor Wand amongst us here today, who is speaking for the first time to the consortium.
Good, Taylor.
Dr. Taylor Wand is a rising HIV specialist based in San Diego. He currently practices at the Family Health Center in San Diego, where he has also completed his residency with a focus on HIV care. In addition, he has spent significant amount of time at the National Institute of Health, where he has contributed high impact research in immunology and HIV. Dr. Wand earned his medical degree from the University of Colorado School of Medicine in 2021. Today, he will provide an update on the latest developments regarding the measles vaccine. Please hold all your questions until the end of his talk. Our goal today is to highlight the importance of vaccination and examine whether individuals living with HIV in San Diego should receive the measles vaccine. This is really important because this is really current. Why or why not? And now, welcome, Dr. Taylor Wand.
Thank you so much. It's really nice to meet all of you. I work with Dr. Curtis sometimes, and he's in Italy right now, so he asked if I could help him with his presentation. That's why I'm here. So we both worked on the presentation a little bit. I'll get started. Yeah, so we're just gonna be talking about current vaccination guidelines for measles and persons living with HIV.
I thought you had to get your measles shot in the US. Wasn't it like a school thing?
We're holding questions?
Oh, yeah. I was asking my friend.
So some of the objectives for the talk today. So we're gonna review symptoms and look at some pictures of measles. We're gonna talk about complications that can happen with measles, review the current measles outbreak in the United States, talk about prevention, list some of the medical society guidelines, and then we'll discuss a little bit after, just any questions regarding the vaccine. So to go over measles a little bit.
Senator Kennedy said.
So some of the symptoms are fever, runny nose, red watery eyes. A lot of people get a skin rash. And it mostly does affect children under 5, but it can infect anyone as well at any age. And then some of the more severe complications can include blindness, encephalitis, which is an infection of the brain, can cause brain damage or death. Also severe diarrhea that can lead to dehydration and also sometimes death if you don't get hydrated properly. Can have really bad ear infections and also severe respiratory problems like pneumonia. So, I wanted to show some pictures of what measles looks like. Probably everyone in this room has never seen measles because it's so rare, because we had really good vaccination rates in this country, and it's the virus not able to spread. But it usually starts off as small, flat, raised spots on the face. And then this is a picture, so it can cause the eye to be red, these Koplik spots in the mouth. this is like a pathognomonic sign of measles, meaning like if you see this, it's measles only causes that, so it's probably measles. And then it causes this rash on the skin. And that's could be what a child looks like when they have it. And then it can be contagious 4 days before and 4 days after the rash appears. So here's a couple of photos of like actual real photos of how the rash can look. And it can be complicated because actually I do some pediatrics in my practice, and there's a lot of rashes that kids get or that people get that can look similar. So we have to really keep a close eye out, and especially on patients that we know are not vaccinated. So that's something that I always ask when I see a patient, they come in with a rash and a fever. One of the first questions is, can I see your vaccines? And I hope they're vaccinated. So I just wanted to reiterate, like measles can make people very sick. So 1 in 20 people can get pneumonia. 1 to 3 in 1,000 people can get this brain swelling called encephalitis. And then 1 in 1,000 people die from it. It also creates a big burden, you know, even if you don't get super sick or you have to go to the hospital. Children have to stay home for a long time. It's super contagious, and that causes parents to have to miss out on work.
You're going into another meeting, so I would go out that way.
And I'm sure a lot of you have heard in the news, we have a measles outbreak in our country right now, especially in communities like in Texas where there's under vaccination. And we actually had a child die from measles, which was the first time in a long time. So that's very sad because it was a preventable death. And routine childhood vaccination provides 97% of protection from measles. So when I'm doing pediatrics in my clinic, we're constantly vaccinating the kids and trying to, it's one of the most important things that we can do for the health of them and the health of the community. And then, so the treatment for measles, you know, we don't really have a great treatment necessarily. It's really supportive care. So this means that we're just trying to be there for the patient when they have it, make them feel okay, supporting them, but there's no like medication specifically that we give. So to talk a little bit about the current outbreak, so there's a total of 607 measles cases reported in 20 states right now. So all over the country, including California. I think it's, you know, there's the Texas one that's really bad in New Mexico right now. And one of the scary things about this virus is it's just incredibly contagious. So, you know, when with COVID and like flu, everyone's wearing their masks, you're scared when someone coughs. But measles is way more infectious than either of those. If you're in an enclosed space, like in this room, and someone has measles and coughs, most people would get it because it aerosolizes and it's just extremely contagious. So that's scary. And then put in this picture just to kind of reiterate, like, you know, our society today is very global. People are traveling all the time. And it's very different than in the past when a virus would spread through a community and then maybe die out because it couldn't travel. Now people are hopping continents all the time and viruses can spread like that. So we just have to be even more careful and more prepared for when pandemics and virus outbreaks happen. These are some of the top 10 countries with measles outbreaks right now. So a lot of these places don't have good vaccination, so they have a lot of cases. And then, so this is in the US, and so that 483 is a little bit old. It's gone up since then to the 600, which I said. And also, like I said earlier, so a lot of the cases are people under 5 years old. But it also happens in older people. And you know, we're even more concerned in people who are immunocompromised. because that affects how you pick up a virus and how it affects you. And then another striking feature is, so out of all of these cases, 97% were unvaccinated or had unknown vaccination status. So really, it's an amazing vaccine and it does a great job. This is the hospitalization rates. When it was the 400 patients, and then I was talking to Dr. Caperna today actually, and so we had one confirmed death and one was under investigation, but as of today, there's 2 deaths that we know is from measles. So what we did was we talked to local pharmacies and local doctors to try and understand better what our community needs in terms of vaccination, if we should be getting antibody levels to really protect us. We asked pharmacies and Dr. Caperna and we talked to these pharmacies and everyone basically said the same thing, is that we're following CDC guidelines for people with HIV in terms of when to vaccinate and when to test for antibody levels. So this is from one HIV society. So they recommend 2 doses of the measles, mumps, or rubella vaccine. So they put a couple different immunizations in one, and it's separated by at least 1 month. And it's safe for patients with HIV who have a CD4 count greater than 200. And you give it to people with no evidence of immunity. So this is how we kind of, there's several different guidelines that we're working with and trying to understand how to approach our patients from. But this is kind of how you determine if someone has immunity. So if they have a medical record saying they've already had the disease, then you have natural immunity because your immune system has fought it off and your body will recognize it and fight it off again. You can also get a blood test that looks for antibodies, and it will tell you if you have antibodies circulating in your bloodstream that can fight the virus, or if it's a low level and you need to be vaccinated again. Also, people born before 1957, they think that you're probably exposed to measles because that was before the vaccine started. So you probably have some immunity. This was an interesting paper that we found though, that showed, it was looking at seroprevalence in people with HIV. So seroprevalence means they took blood samples from the patients and looked to see if they had antibodies against measles to show if there was immunity to the virus or not. And it came back at 70%, which is pretty low, actually. We were hoping for like greater than 95% immunity for people who have had the vaccine, because when 95% of the population has immunity, it protects the whole community. And when it drops below that, a lot of people become more at risk. So we also talked to local HIV medical providers at family health centers and AHF, and it was pretty consistent with what we've been hearing, that there's none of these systems necessarily have guidelines out yet for how we should be approaching this. It's new that this outbreak is happening in the United States. But a lot of people are giving the 2 doses. Some people are checking antibody titers. And I was talking to Dr. Caperna about this, and some societies, some guidelines say we should be checking antibody titers on everybody with HIV just to see where you're at, see if you still have the immunity, because people with HIV, their immune systems are different, so you can lose that immunity quicker. So we were thinking, it's good to check for all of us to be extra careful. And probably like if you haven't had it checked in 10 years, it's a good idea to check it again, because it's just a blood test and it will show you if you have immunity or not. Some guidelines say that you don't need to check. As long as you've had the vaccine in the past, you were born before 1957, or you had the infection in the past. But we're erring on the side of caution. And I just wanted to reiterate that the evidence continues to show that the measles vaccine it's very safe and effective for people with HIV. As long as it's controlled and the CD4 count is above 200. And I thought this was an interesting graphic that I wanted to show. It just shows like how amazing the vaccine is and how powerful it is. So it's a timeline, and yeah, the vaccine was licensed and started to be given out in the 1960s. And as you can see, there was a ton of measles cases, and then we started vaccination and it plummeted. So that's the bottom graph. And then the one in the upper right corner shows that since 2000, it's slowly been creeping up again. And now there's like that big bar. And a lot of this is because there's a lot of vaccine hesitancy and misinformation out there about vaccines, which makes people scared to get their vaccines. And then they don't vaccinate their kids, and now we're having a spike in measles, and children are dying. So this is just talking about prevention and kind of herd immunity, which is what I was talking about earlier, where if we can vaccinate pretty much everyone and get 95% of people to have the immunity to measles, it cuts it down for other people in the community, especially people who are vulnerable, who maybe have the lower CD4 count, so they can't get the vaccine. They're at really high risk. But if we have herd immunity, meaning 95% of people in the community have immunity, then they'll be much safer. So that's our goal. And then we kind of talked about this. So if you have lower than 200 CD4 counts, it's contraindicated. We don't give it just because this is a live vaccine, live attenuated, meaning it is the live virus. It's altered because they pass it through different organisms that changes the genetics of it, so it can't cause severe disease, but it is live. So if someone has a really suppressed immune system, we do not give it. So some of the key points that we talked about today. So the MMR vaccine is safe for people with HIV as long as the CD4 count is greater than 200. And we recommend getting it, especially now that we're seeing cases rise and it's so contagious. And there are serious consequences for some people when they get it. We recommend that you talk directly with your doctor, healthcare provider, about measles, about getting the vaccine, your immunity, so you can know where you're at and know if you're protected or not. And then one more time, yeah, so the complications, it can be that swelling of your brain, pneumonia, really serious things, and 1 to 3 people can get the brain damage or die from it. And also, people with HIV are at a higher risk of complications just because the immune system is changed from the HIV virus. So it's especially important for us to make sure we're up to date with our vaccines. And these are just the societies that we got the information from. So thank you so much. I appreciate you guys listening.
Thank you. Dr. Do you know, do you have any statistics for how many people, for how many people, are there any in San Diego, how many cases there are? And more specifically, do you have any HIV patients that have acquired?
Yeah, that's a good question. I have not, none of my HIV patients, and I have never seen measles. So I don't know, have you guys heard that anyone in San Diego?
I'm in San Diego currently, the outbreak is in Los Angeles.
Yeah.
But it's a matter of time before we see children
Of
who are
course.
unvaccinated that develop measles here.
Yeah. And the thing is like, we haven't seen it documented, but that doesn't mean it's not out there in the community.
Absolutely.
And they just didn't bring their kid to the doctor.
I just wanted to clarify the recommendation for us as a group, or me personally. I've had measles as a child, and I have HIV. So should I be serotested or should I get the vaccine or am I okay?
Yeah, so, there's different guidelines right now saying different things. You are probably immune. You had it, your body had a strong response.
Right.
But
Yeah.
it doesn't hurt to get tested. It's just a blood test that looks for antibodies, and then you could make that shared decision making with your doctor. Once you see, oh, I don't have antibodies or I do for this, whether you should get it or not.
So that would be serotesting, right?
Exactly. It's like a
Okay.
blood test for antibodies.
Okay.
Back there.
Yeah, please.
Okay, actually, for a long time. One of the problems with the things that most, except for Crosby, Marvin, and possibly Jason, all of us are older than the population you're talking about, and we actually went through a period where it was required in school. Now, I do know that I knew a woman that about 20 years ago, she actually she's in our age group, but she had lost all her immunities and things like that, and caught illnesses that basically would normally sit there and not occur. But like I said, that was 20 years ago, and so that has been identified, and we said, no, our problem, the problem I have with all our group in particular is we don't get the younger people in this group. Which we're talking about very good information, but for the most part, it applies to the younger people. Because we actually went through the period, I mean, I was born before myself, but I remember people in my family getting the measles, and I think I may have, because I remember the itching and things like that.
Yeah.
But it does not, because we're older and we've already gone through this, this whole thing about that doesn't apply to us.
So I
Let
think-
them form their own group.
I think it's a little bit unclear though, that, you know, you did have it as a child probably, but
Most of us.
but it's still good to check to see if you have antibodies, because
And that's why
it might have waned
That's
over.
exactly what I'm saying, because of the fact that I do know only 20 years ago, they got it. During that particular period, they literally started making sure that, I know I in particular, was tested again to make sure that we still had those childhood immunities. But I would imagine if we were in care at that time, that was already done. So,
I lost immunity. I was vaccinated, but with the military, you're required to.
yeah, that's what I'm saying. We were, like I said, so what you're talking about is important, but not for our age group.
Okay, our time crunch here. Sorry. to cut you
But
off.
we could have lost immunity, so it is.
Just get tested. Get tested.
Get tested.
Okay, we have two, Marvin and we have Crosby from the HNRP who are here to just give us an update.
Go research.
And hear from where you are, guys. Yes.
But just please add that Dr. Steve recommends surround yourself with vaccinated people, community vaccination is.
That's right.
important.
Right, just, that's a question for any time you're dating.
Visit the Kennedys and for it.
Go ahead, Marvin, go ahead. Please.
Are biomedical in nature, so we test a lot of up and coming drugs. We try to find new treatments, peer-related research. We're kind of in a slow period right now. Also, we're kind of in a pause because our funding is actually at risk by the current administration
Great.
right now. So so at the current time, we're only enrolling in industry-related studies. Right now, we're working on so any of our federal funding is kind of on pause. So every week, I'm looking at seeing what's being cut. Actually, I have a lot of colleagues where their funding has been cut if it's related to anything DEI related. So if it's Latino, women, Black, trans, it's all being gone. Just FYI.
Yeah, marginal people.
Yeah, so it's very, very sad.
Horrible.
And every week you can go to a website called tags, TAGGS.HHS.gov. Every Friday, they list a PDF of every single study, all COVID gone, women gone.
And this is Elon's shit, right?
It's all that,
Yeah.
everything. Every Friday, every week, I download the list
Ugh.
and I'm seeing everything that's being removed. So it's very, very sad. But the studies I'm focusing right now is we do what's called Purpose 3, which is very exciting. It's a PrEP study, twice a year injectable called lenacapavir. It's focused on women, this one for any cisgender woman that's sexually active. And then there's Purpose 4, that is looking at any gender for people who inject drugs, okay? Hopefully, fingers crossed, this summer, we're focusing on an ACTD study for women, hopefully, who have HIV that are perimenopausal or premenopausal, that we're gonna be testing a estradiol patch with or a pill to see if that can help with hot flash, or perimenopausal symptoms. Yeah, so, but we're really hopeful that that's gonna get funded because that's women research.
Yeah, which is always.
I haven't started yet, so I'm gonna be looking at that list every Friday to make sure that's not gonna be cut.
Jeez.
Right? And then the other study that's coming up is looking at pre-frail or frailty. So that means basically people that are having weakness, maybe trouble walking, people that have maybe trouble falling. And so taking 2 different medications to see if that helps with improving kind of weakness and physical function. So that's any gender living with HIV. So those are 2 studies that we're hopefully going to get funded that's coming in the next few months. So those are the 2 things that are up and coming. Okay.
Currently, don't you have some
So thank you.
openings? Thank you, Marvin.
Oh, well, also, the ABRC has a community advisory board or CAB, very similar to like this kind of community meeting. We meet every Monday night, the first Monday of every month at the ABRC. So,
So if you come to this, you just have to remember that Monday you go to the meeting.
yeah, we do the same thing, but that's what Rachel's mentioning. So.
And then next Thursday at the HIV discussion group here at the center, Marvin can be our guest speaker.
All right. Okay. Very ready. Hey, Mark. We got Crosby.
I'm not gonna take much of your time, I know we're at the end.
We
here.
still got 4
I
minutes.
just wanted to, I wanted to advertise one of our newer studies that we have, as you know, we do neurobehavioral studies at HNRP, and we are Marvin's sister research site. So we're called the HNRP, which is HIV Neurobehavioral Research. But this new study has to do with cannabis. And we're looking for either people who have little to very zero experience with cannabis, that have pretty much never used it in their life. And then we're looking for the people who are like the heavy cannabis users. And those are the ones who dab or vape. And if you don't know what that is, it's a more concentrated form of cannabis that is used in either a pen form or a rig. And it's for people who have moved up on their cannabis use.
Professional.
Yeah, they're professional. Right. So in this study, we drive a van out to your location, and there's a driving simulator inside the van. And we're looking on how dabbing and vaping affects driving performance on a simulator. But as I said, we're looking for both groups, people who don't have experience and people who are very experienced. There's a lab inside the van, so they'll do a blood draw right in the van.
You get to get hard?
Only for the users. Yes, and the non-users, I'm sorry? It has nothing to do with HIV, believe it or not.
What is dabbing?
It's like a wax or a very concentrated form of cannabis that is burnt with a torch. It's pretty serious.
Yes, and a rig is people that inject it.
Inject cannabis.
I know it's.
I also want to say that they pay for their studies. So it pays, yes,
And we come to your house.
it pays quite a bit to be in a study.
There's a 55 age cutoff limit. Thank you for. Sorry about that.
Okay,
Please.
Wanda, you're next. Wanda, please.
I appreciate everyone coming here. We're gonna end the session. On time, everyone tell all of us.
On time.
And 12 minutes meetings and walk, when we sit there, ready to jump off the chair. No, I want everybody to be safe. Please be safe when you go downtown today. Do your walk for what you know is right, but I want you to be safe, okay? Do not allow anything to get out of hand with you guys. I love you all and go.
All right.
If you want some of the food, you can take some.
Thank you for attending. Thank you for viewing.
Go to the mark.
All right.
Yes.
Thank you.